Uh, this is our first Harborview Ethics Forum where we've met together for the last several years. Not since the pandemic have we had an in-person ethics forum, so I'm glad to see all of you who've come. I know there's more people checking in. I can see them across the hall, but we'll get started now. Today we are really fortunate to have Ms. Sarayah Brenda Obonyo speak to us about Pulse Check, Trust, Power, and the Architecture of Care. Before she speaks, we have to do a few slides. If you want to get credit for this talk, CME credit, you can text this number and also use that activity code. And then fill out a survey afterwards to claim your CME credit. We will be recording today with permission from the speaker. And I hope permission from all of you as well. There are no disclosures today to announce. I want you to save the date for next month's ethics forum. Dr. Tanya Shaw, who was a graduate of UW School of Medicine, will be speaking to us. She was recently serving at a hospital in Gaza and then returned to Seattle with a severe illness, going from doctor to patient. And she also has a story to tell. I also want to remind everyone that there's a program at the University of Washington for advanced training in healthcare ethics and a summer seminar program. There's a QR code if you want. So maybe sorry. I have a low. The objectives of today's talk is to recognize how early clinical assumptions and electronic health record documentation can influence patient trust and diagnostic decision-making, to identify ways that clinician communication style and clinical posture affect patient engagement and willingness to return for care, and to describe how documentation accuracy and information flow between clinicians influence downstream interpretation of patient symptoms. Ms. Sarayah Brenda Obonyo is a graduate student in information management at the University of Washington. She's also a patient advocate whose work focuses on how information breakdowns in healthcare contribute to diagnostic delay and even patient harm. Her master's research practicum, When Information Fails, Diagnostic Delay and Information Breakdowns in Rare Disease Care, examines how gaps in information flow between patients, clinicians, and healthcare systems shape clinical reasoning and delay life-saving diagnoses. Originally from Nairobi, Kenya, Ms. Obonyo began her U.S. education at Edmonds College, where she served as the student body president before transferring to the University of Washington to study informatics. She currently serves on the Patient and Family-Centered Care Steering Committee for UW Medicine and will graduate, with her master's in June in information management. I am so grateful that you came to speak to us today, and happy to introduce Ms. Obonyo. She's a patient, an advocate, an information processor, a systems analyzer, and she has a story to tell. Thank you for being here today.
Thank you for having me.
Get how to act if you ever.
Yeah. Hi, everyone. I'm very happy to be here. I've been looking forward to this day for a long time, and I wanted to make this as personal as I can. And so I'm just going to talk to you like I'm talking to my friends, and let's see how that goes. So as you've heard, I am a student at MSIM. I mean, UW, University of Washington. Sorry, we're so used to the So before my illness, I was born and raised in Nairobi, Kenya, in a very tiny slum called Mathare. So there are things like food and housing were insecurity were kind of things that I lived with. Getting an education was something that I had to fight for, but was not guaranteed. And I eventually came to the United States and I started doing odd jobs here and there, and then hurt my back because I have fibromyalgia. And I thought to myself, I need to get a degree, at least an associate's degree, so that if I don't work, if I work, then I don't have to stand the whole time I'm working because I'm not physically able to. And so that's started the journey of me getting into education and then discovering that I could do anything because I had a mentor in a program called Mathematics, Engineering, Science Achievement, MESA. She told me that I could do anything. So when I would have crazy ideas of I want to study statistics, she'll be like, okay, go to UW and see someone who teaches statistics and see. So eventually we landed on informatics. And that's how I ended up doing my associate's degree in physics at Edmonds and then transferring to University of Washington for my informatics degree. Now, why am I telling you this? I am telling you this so that you understand just how much this diagnosis affected my life. In August of 2021, I was in San Francisco on a vacation. I had just finished my internship at Wells Fargo. So I was really changing things up in my life and hopefully I was thinking my community too. And so I afforded my first vacation. Went to San Francisco, went and watched Hamilton. I was living my best life. And the next day I was like, let me go to Alcatraz. Then I pulled a muscle. The muscle wasn't healing. I thought I pulled a muscle and I stayed with it for 2 weeks and I wasn't healing. And I came back to Washington and I was like, you know what? Let me just go find out what's going on. I went to a community health care center and they said I had an aneurysm, a 5.3 centimeter aneurysm in my ascending aorta. They also said I had blockages in my arteries, in my arms. I wish I could tell you the names. They also said I had a tumor in my carotid artery. And eventually, a vascular surgeon told me I had Takayasu's arteritis. And this happened just as I had just signed my full-time offer to start at Wells Fargo. At this time, remember, I come from poverty, so I did not have insurance or anything like that. So that means anytime I tried to call to set up an appointment, to schedule something, I wasn't getting HUD. There was no access to doctors. There was no access to, like, do you have insurance? No. Then I was like, you can just tell that there's a holdback. And eventually, I was sent to a cardiothoracic surgeon to evaluate because of my aneurysm. And this is where my journey with advocacy started. Because when I went to see the cardiothoracic surgeon, I read his notes after, and his notes said that that he had discussed with me, and I had what was it called? A valve. I needed a valve replacement. And we had discussed between mechanical and biological valve replacement. And I know I did not have a problem with my valve because I had just gotten a TEE done and it had showed that everything was okay. I just had an aneurysm. And here is my notes from the surgeon who's supposed to cut me open to do my open heart surgery, thinking that he was going to do, I mean, it's crazy. And so I sent him a message, and I think there was notes about me having diabetes, which I didn't have. And so I sent a message and was like, "Hey, what's happening? I don't have this I don't have this. I feel like this is a problem." And after that, I just got silence. I tried to call to set up appointments. I mean, I had a 5.3 centimeter aneurysm, and my friends who were nurses were telling me, "You cannot be living like this with this." And there was just no hearing. So what did I do? My friends think I'm crazy, but I did realize that I am a student at University of Washington. At that time, I was a student. I had access to University of Washington, the hospital, and I also had a UW email. So I said, I'm going to email the chief of surgery. I Googled, I emailed the chief of surgery at UW, and I said, I go to a different hospital. I feel very neglected. I don't have insurance. I have Takayasu's. I have a 5.3 centimeter aneurysm. And he said, I don't do this surgery, but I know someone who can. And so he introduced me to a certain very nice man that I call my Superman. Because 2 days later, I had gone to his office. He had set me up with a vascular surgeon, a rheumatologist, a whole team in University of Washington now. And I still didn't have insurance, but it seems like they just wanted to save my life. And that was the beginning of it. And I realized that, and I didn't know that being an advocate was something that I was going to do through the 4 years I have been doing, being a patient. And the thing is, when you have such a chronic illness, having to you have to navigate insurance, you have to navigate the doctor, you have to navigate radiology, you have to see so many doctors, physical therapy, see many. It's so hard that the person who's supposed to help you, the doctor who's seated right in front of you, should not be the one you have to try and convince that you need help. And I was lucky because this is just my little spray slide. I was lucky because I was a student. I understood how the institution worked. I understood the language I could use to get what I needed. But most people do not have that. And they shouldn't have to. Anyway, so I came with a few stories of wanting to just sharing. They're all my stories, they're my truth. I'm not trying to attack anyone. And if anything, I want us to just think about what could have been done different. How did this affect me as a patient? What was the impact? And how is this affecting other patients? And how can I, as a clinician or a medical practitioner, help? Or what part can I play? So I'll start with my visit to emergency room. I went to the ER because honestly, at this point, I can't remember why I went. It probably was a chest pain. I go to the emergency room almost all the time. So I went, and because I go so much, Epic had sent out an email, and I think it had meant to send that email to the doctor, but it sent it to me too. And it said that I it flagged me as a frequent flyer. And they said something about the doctor needs to talk to me, counsel me about drug use. Anyway, so by the time the doctor was coming into my room at the ER, he had already formed an opinion about me. And his first questions were, "Do you have diabetes?" I said, "No." "Do you have high blood pressure?" I said, "No." "Then why are you here? You seem healthy." See the two things he asked? I'm a Black woman. Blood pressure, diabetes. If I don't have this, then I'm healthy. What am I doing there? And then I laughed and I told him, I don't think healthy is a word that someone has used to describe me in a very long time. And then I was wearing my gown, so I pulled the gown. I pulled the gown and I had to show him my scar for him to treat me. And he did. He changed. He was like, "When did you get that?" I said, 2022. And he was like, everything just changed. He asked for like CT scans and he was emailing my rheumatologist and emailing my neurologist. And just because now he was like, you could have a blood clot. And so things really escalated. And I was like, okay. But before that, it was just horrible. And I did try to reach out to patient relations, and I did, but because of the documentation, the way it had been done, they hadn't documented the first big, all they could see was the emails he sent to my rheumatologist, my neurologist, to everybody. So I remember he also asked me, why are you here? Don't you know that this is a hospital for, no, this is where you come for big things? And you might think that that was just a normal, well, I don't think that's a normal occurrence. That was a terrible thing. But the impact of it was real because a few months later, I lost my vision. And I was so scared of going to the emergency department because of just how bad I had been treated and even how I didn't get help with the patient relations. And so I just didn't go to the emergency room and I lost my vision. And eventually I told my rheumatologist, and she was like, okay, we need you to go to the emergency room. We need you to go get help. And she called ahead and she made sure that everything was okay. But she had to give me a talk about how important it is for me to go to the emergency room, that they get to decide whether I have a problem, whether this is a serious thing or not, but I don't get to decide. And I should go at any time. And that's just one of the situations I had. Situation number two. It's not always bad. We have good times too. I 1 week into my master's program, 1 week into my master's program, my legs stopped working. I could not stand, I could not walk, I could not do anything. I had functional neurological disorder. And so that meant I stayed in hospital for 1 month. I think it was 1 week just in hospital trying to figure out what was wrong, and then 3 weeks of acute rehab. The thing about the people at the rehab that really stayed with me is that they really supported me. They found out that I was a student, and so they rescheduled all my appointments to be in the morning. So in the morning, I would have 3 hours of rehab, and then I'd rest for 2 hours, and then I would have my assignments. And I did stay in school because they would come and wheel me. They would put me on a wheelchair and take me to a room in the afternoon where I would be by myself and I would do my assignments. And they would bring me drinks and they would bring me food and pudding. They made sure they made sure I was okay and they supported me through that. And that wasn't it only. So my degree is very much discussing ethics and discussing information and society. And so the things we were learning, I didn't have the opportunity to discuss it with my classmates. And so my physical therapist and my occupational therapist really just stayed with me and allowed me to just process everything I was learning by myself. And so my physical therapy, he probably knows a lot about business management, information management that he ought to know. But that was just it. And what was the impact of that? I was a human. I stayed there for 1 month, but I mean, it's horrible to stay in hospital for 1 month, but I was taken very good care of. I still run when I see my CNAs, the ones who took care of me. When I meet them, I run and I hug them because they were there for me in my deepest, like in my darkest moments. And I get to graduate in 2 months. So thank you. So that was an excellent outcome. Yay, rehab. And then another good one is I spend a lot of my time in hospitals. So I see neurology, primary care. I feel like I see all of the things, all of them. But I have this team of doctors, the ones I see often, they involve me in the decision making. They ask because my disease is very rare and it's scary and rare and we don't know much about it. So it's like, what do you think we should do? Sometimes I'm like, do they know I don't have a degree in medicine? But they are so good. And then remember how I've been so sick for so long. So I have a distortion of pain. I don't know if something is bad or if something is good, or I don't really know. And my rheumatologist sat me down and she had told me, whenever you feel something new, when you have a new symptom, you email me. I choose if what you're going through is an emergency, if it's something to ignore, if it's something to escalate. I decide, not you. And that's how we keep you alive. And I think that gives me such joy, and I feel safe and I feel like I have autonomy over my life and I feel like I am part of my own care and I'm heard. And then, it can't always be good. So while on one of the things they use to treat Takayasu's arteritis is prednisone, the drug we love to hate and hate to love. So prednisone caused me to have a vascular necrosis. At first, it was at the knee, and I was sent to a sports medicine doctor, and I told him I have pain. It was incredible pain. And he said that where my AVN was, it did not explain the pain I had, so it was in my head. He actually said the pain is in your head. But I insisted because Sarayah had learned about advocating for herself. So I insisted, I said, you have to at least get an X-ray done. we had back and forth, and he eventually, just to shut me up, got the X-ray. The X-ray came back. He wrote in his results that everything was fine. There was no new findings. I go read the X-ray report, and the X-ray report says that I have hip AVN. And if it can be seen in the X-ray, it means it has progressed to a point where they need surgery. He wrote everything was okay. So, of course, and my rheumatologist had, of course, when she looks at the notes, she sees that it says that I'm okay. And then I tell her, no, I have AVN. And that's why I have that walker. And we're still trying to figure out how to do that. But that is dangerous. And I'm not the only one who gets to experience this, especially with documentation. Because when I talk to many patients, they really say when they look at the documents that the documentation that it's been written, it's not always right. And the thing is, the next person who gets to read that, they're not going to read my whole history. They're just going to read what the last doctor said. And if the last doctor said everything is fine, then where are they picking up from? So I have a few questions for us, just something to ask ourselves. How do our systems prime perception before patients speak? How do we support patients who cannot escalate? How do we ensure that documentation reflects reality? And in this age of AI, how do we protect the privacy of our patients? I don't like leaving things with bad, so let me just give you one good example. Every 4 weeks, I go to the infusion clinic at UWMC to get my infusion for my Takayasu. And it's a treatment that is 4 weeks and you go for 4 hours. And it is supposed to be draining. And most of the time I'm complaining. But when I'm there, I'm supported. They know, because I have bad hips. They know which seat I sit on, very particular. They give me that. They know I will fall asleep because of Benadryl. I'll fall asleep and wake up after 2 hours. And they know that when I wake up, I always ask for pudding. And so they always bring pudding just when I wake up. And I never have to ask. They are so kind to me that they have taken something that is so emotionally draining and made it something that I actually look forward to sometimes. So patients shouldn't have to escalate. They shouldn't have to advocate for themselves. The question shouldn't be, did the patient survive? But the question should be, did they feel safe? What experience did they have? Did the system hold them? Did we hold them? And maybe if we think about that, then maybe we can make a difference, one patient at a time. And so that we don't have patients who don't come back to the hospital because they're scared that they don't have a big thing. We don't have patients who are told they're there to look for drugs. We don't have patients who have to email chief of surgeries. Don't do that. That's crazy. Yeah, so let's just think about that. And that's all I had to say. And I will welcome questions.
I'm a consultant in different health system. The story is not about he does this stuff. But I yesterday had a case where the patient, who's a woman of color, has diagnoses in her chart that relate to things that are not physically shown, and whether is it all in their head, et cetera. Patient comes in for the same things all the time. And we worked together with her team, who was having a lot of frustration, and the patient was having a lot of frustration. Try to get together a kind of care plan of like, here's what we know, and here's what we know works, here's what we know doesn't work. As far as, because they were spinning their wheels in different treatments each time. And I'm wondering if you still end up going to the ER, and I don't know, but if you do, is there a way that something comes up where they're like, oh, we know you, we know what to do when you're here kind of situation, or like, we don't have to go through this whole, like, who is this person? And is there a way that you can get that kind of personal attention in the ER when it's not like the doctor who actually knows you personally?
So at the UW-MC, the one I go to now, because I don't go to that other medical facility, but the one I go to now, they have I go too much. They know me. So that's that. But also they have a message that holds that I think it's an EHR thing that sends them a message and tells them a little bit about whatever I am, but it is not efficient and it's not enough. And sometimes you end up, it always comes back to, please go read my notes. Because if I'm very complicated, then if you come to my room like just the way you come to see any other patient, then we're not going to help each other. But usually it's read my chart. And I know it's hard because it's the ED, but that's how it is. Maybe the systems people could think of coming up with a thing that just puts it together in a healthy way. Any questions?
Oh, sorry.
Do you think, as a patient advocate and just in your own experience, that chart notes taken with AI might, like, how do you balance that and what do you think about that? Because I know a lot of systems are moving toward that. Do you think that has the potential to be good in some ways? And I mean, obviously there's the privacy issue, but what other issues do you see?
Okay, so interesting question, because that's my field of study. So I study data governance and implementation of AI that has responsible AI basically. And I feel like the way that for you to use AI in healthcare, you have to understand how AI works. You have to understand the epistemology of AI. What biases does it have? How does it hallucinate? How does it process this information? How is that information stored? How is that information used to train the data? Like there's so much that goes into what AI can do. So if if the health system introduces an AI system to patients, how are they getting consent? Because I'm seeing, I think I read it on a note that said there was no need for the patient to get consent because we didn't record using, I think it's ambience or whatever. I don't remember the name. And how are they going to understand my accent? My own ChatGPT, and Google and all of them, the ones that I use constantly, they do not understand my accent. So if we leave the AI to record the conversation and write the notes, then what is it recording if it's getting the wrong information, if it can't even understand what I'm saying? And then the data that we're using, the story, I come and give you my information, you record it, it does the notes for you. That's great. Where is my information going? Who has access to that? Have we thought about that? So I'm not saying I'm anti-AI. I am really, let's get with the program, but let's do it responsibly. Let us put the patient first, especially because it's a power move if a doctor walks into a room and says, is it okay if I record you? This is just going to record you, and while we talk, it does nothing. How am I going to say no? So, sorry, I didn't mean to get so, but yeah, there's a lot there.
We have a few questions from the chat too that I'll raise up. First of all, just a lot of gratitude. We have about 60, 65 people online attending, and just a lot of thankfulness and gratitude for you being here and sharing your story. One of the first questions is, what are your thoughts on the transparency of electronic health records? That is, what do you think of patients being able to see provider notes and respond to them?
My opinion is that I like information. I like knowing. And it's in the knowing that allows me to call out when something isn't right. But I also know that it can be dangerous, especially if I get information about like radiology results and I Google it and it says I have cancer and I died. And not I'm dying, I died. And so I think it has to be a balance. I feel like the things like the notes and the patient summary, I feel like those should be transparent. We should all have access to that. Even the results for radiology, but they have to be done responsibly again. So it's which kind of tests are we just allowed to take out, like CBC? And why do I know this? But CBC. And then MRI maybe. Why don't we wait for the doctor who asked for it to see if they can get? There has to be a balance. I don't think there's one good or bad way, but it's just a very delicate balance we have to do.
Thank you. Another question from the chat before we return to the room is one person commented on the fact that we have medical alert for complex patients in the ED, and care plans, including in the ED, to alert providers of specific needs. And I don't know if you have any other addition, there's anything to share to that, but just a comment that somebody made.
I don't know. Do all the doctors know? Because do they know that that exists? Oh, then that's okay.
But sometimes it might say this person comes to the emergency room frequently. Yeah.
That. And then they said, let's talk to her about drugs. So I don't know.
And maybe that goes back to your comment about balance and participation and transparency. It's one thing if the care plan alerts providers to, things like what Jill just suggested, right? Frequent admissions or something like that's a different sort of thing than if they've collaborated with you on what should be in the care plan and alert providers to when you come in. Do you think? Yeah.
Yeah, I think a good practice would be maybe with primary care. They have a way of just feeding the system and telling the system that this patient struggles or is at danger for this, and this, so that it is clearly documented, not randomly just created by technology, but more like it is, what's the word? You consciously choose to feed the computer the technology, what it needs to say about the patient. That's what I think. Yes. Oh, sorry.
Mine is just a comment. I'm so proud of you. You're doing big things. You came a long way, but you're doing big things. So proud of you. Thanks.
Thank you. I paid her to say that.
This is Barbara Showalter online. Is it okay to make a comment?
You say yes.
Yes.
Okay, so I'm a doctor, had my own family practice, solo practice for about 25 years, and then I've been working in the prison in California since then. And I just want to fully echo how important the information is that you've shared about how you can be affected by people's prejudices, prejudgments, mistakes. I have a number of different things I could share, but I'm just going to share one from many years ago when I was taking care of a type 1 diabetic man who'd gotten the diabetes when he was about 19 and he was now about 27. And he was severely affected by gastroparesis, where the nerves to his stomach just weren't working, and he would vomit up food, and we were trying different medications, but he kept being in terrible pain and going into the hospital because he was going to diabetic ketoacidosis. And even in the hospital, one day I went to look at him and he was all kind of curled up and obviously in pain and hot, like he had a fever. And I went and told the nurse, hey, I think he's got a fever and he's getting sick. And they said, oh, I think maybe he was just, lying on that side and covered up. I said, please get a thermometer. And you had a temperature of 103. So he could get DKA even while in the hospital. But in any case, the thing that really hurt and ended up ending his life was because one time he was a really nice guy. He would make little jokes with the nurses. One night I was on call and at home, and one of the nurses at night called and said he had said something about shooting her or somebody. And I said the only thing it could have been would have been a joke. And it turned out this nurse had some hearing problems as well. But she called. I said, I'll talk to him in the morning. He has no guns. He's fine. But they called the security guard, who spent an hour berating him in the middle of the night for threatening the nurse, which he had not done. The next time he got DKA, when he was staying with his sister, she was going to call the ambulance, said, no, don't call the ambulance. And so she let him go back to sleep. And the next morning he was unconscious and they brought him to the ER, and he was, his acidosis was so bad, it was like 6.91 or something. He died that day. And he died because he never wanted to go back to the hospital again after that happened. And that kind of being able to care about people, to listen to them, to have compassion and share what they're going through. And as you so eloquently described, the people who made you feel safe and valued and knew you, that's what's needed when illnesses and life are very difficult. So I thank you for sharing that, and I wish there was a way to better, I don't know, better train all of us doctors, all of us caregivers, all of us medical staff, and all the families to be able to really truly listen and to imagine what it must be like to be very ill and not know what is going on, be very frightened, and then additionally have to deal with people thinking that you're just there to get drugs or whatever other story they're telling themselves about you, because they can't. I think it's sometimes because they want to. It's scary that this could happen to anybody, and they want to make it somehow the person's own fault, that they will never get it themselves, and they just close off those gates of empathy. Thanks very much for listening.
Thank you for that.
Hello, I'm Tim way back here. I so appreciate your talk. Thank you so much. I am ruminating on the concept you brought up of the narrative preceding you before you show up at the doctor's office to the provider's office. And I'm wondering, I'm not sure it's practical in every instance, but what would it have felt like for you to have a provider say, sometime during the conversation, after we meet, I'm going to go to the chart. What would be important for you for me to add to the note?
So I'm not completely sure I understand the question. I'm sorry. Do you want to say that again? I'm sorry.
Thinking about the narrative that gets passed down in the chart, the pretext before you even arrive, people becoming aware of your story. How would it have felt for a doctor, for example, to say to you during an appointment, after our time, I'm going to record my thoughts about our conversation. As I do that, what is important for you as the patient to have recorded in your chart? What would that have felt like?
I think I don't have to imagine it because it actually happened. I have had one of my doctors, actually my primary care, our first conversation, our first time meeting. I met her after, I think I was in the system for 3.5 years before I met my current primary care. And our first conversation is, I went through my chart. I went through my chart, and there's so much there that is not true. And we spent 1.5 hours going through my chart and removing things and discussing medications. And we ended up even calling some people who I needed to be referred to. And so I have felt that. And of course, I told everyone we're sticking with her and she's going to be my doctor forever. But because I have Takayasu's, to be honest, it would be nice to have a note that says, when I say something like chest pain or just, there's always danger for my vascular problems, right? And they're not always going to look like, it's just a stiff neck. Stiff neck turns out it's a dissection in my vertebral artery. So I don't know, just be extra careful. But then there's also another aspect, because I have been sick for so long. I have trauma, like PTSD in the emergency department, right? And usually I'm very good at communicating, and I tell my doctor, the people, the nurses and the people, I'm like, I know I'm very calm right now, but I might get to a point where I will ask you that I want to go home, regardless of if you have treated me or not, because I am very anxious. If you don't give me something to sedate me, I am going to leave this hospital. And I don't mean it in a terrible way. I just mean it in a, this is how I am working through it. This is what has happened for the past few years. And so for some nurses, they're like, oh, what do you need? Let's calm you down. Others are like, please tell us more. Until I freak out and I'm like, I need to go home, get me out of here, and it's really real. It's like, get me out of here. That's when they're like, oh, she told us that this would happen. And so if that could be written in my notes, because I remember even asking my therapist if that was something that could be written in my notes, that I honestly do not want to go. But when I'm there, it's like something else is there. I just like, get this out of me. I want to go. So if they could just say sedate her, like I saw when I had a problem with my eyes and I came to Harborview and I was at the emergency department and I told them, I think I'm gonna go home because this is too much. They're like, what do you need so that you stay here? Because you are in real danger. At that time, I had like pressure in my eyes. Like, you are in real danger. So what do we need? And I told them, you gotta sedate me. They gave me everything and they kept me there for a full day. Just so they were like, whatever you need, we will get it to you as long as we keep you safe. And I thought that was really nice. So I hope I've answered.
Ms. Obonyo, thank you so much for talking to us today.
It was my pleasure.
We can sit here a little more if you want to come up and ask the last few questions, but there is some food that we weren't able to eat in this auditorium that I welcome to you to enjoy right now. And I think everyone who's joined